عليكم جميعا ورحمة الله وبركاته. بسم الله الرحمن الرحيم. Tonight's dental talk is on tooth hypersensitivity. Okay. So tooth hypersensitivity, or also known as dentine hypersensitivity, is tonight's dental talk. So this is a little bit about myself. So I'm a general dentist with special interest in orthodontics. I qualified in 2006 from, well, it used to be called Guy's Hospital, but then they merged with King's College and St. Thomas's. So I actually graduated from Guy's, King's and St. Thomas's dental school back in 2006. And then in 2007, I started working in a Pearl Dental Clinic. And then in 2016, I completed a certificate in restorative dentistry at the Eastman Dental Institute, which is in London. And then in 2020, I completed a certificate in orthodontics at the University of Warwick. Okay, Warwick is it's near Coventry. It's not too far from London. So dentine hypersensitivity, also known as tooth hypersensitivity, it's reported to be it's reported to affect about 1 person in 10, so about 10% of the population. Although the incidence is likely to be much higher. So there are anecdotal reports that the incidence of tooth hypersensitivity can be as much as 40% of the population. So it's very common, 40%, 30 to 40%. It's described as as a rapid in onset. It's sharp in character, and it's transient in nature. So transient means it's fairly, it doesn't last. It's transient. It doesn't last for long. It's sharp in character. It's very rapid in onset, and generally it's described as pain derived from exposed dentine in response to some form of stimulus. So it can be a chemical stimulus. It can be thermal. It can be a tactile, for example, whilst eating. It can be also during drinking, so it can be osmotic stimuli or tactile during eating, and chemical or thermal. And it cannot be explained as arising from any other sort of dental defect or disease. So, for example, it's not toothache. It's very rapid in onset. So the Canadian consensus document has described tooth hypersensitivity as sort of, this is the description that they have given, and it's a form of pain really due to exposed dentine. Okay, so we have the structure of a tooth here, as everyone can see. So this is like a molar tooth, and we can see we have the outer layer, which is called the enamel. The outer layer is very hard. It's a very hard substance. It varies in thickness from teeth to teeth and from the different position of the tooth. So it can be thinner near the gum, and then near the tip of the tooth, the enamel is usually thicker. But it can range from a very little amount up to sort of a millimeter, up to more than a millimeter or so of enamel thickness. So it's a very important structure of the tooth, as it's the sort of the outer layer. It's a protective layer. And then we move down into the dentine, which is below the enamel layer. And the dentine is where really there are cells there which are alive. These cells are called odontoblasts, and these cells they're present in the dentine layer. And there's different types of dentine, primary, secondary, and tertiary dentine, but we won't go into the different types of dentine in our talk tonight. And then, as everyone knows, there's a pulp, the nerve of the tooth, which, as you all know, that's inside the tooth, in the middle of the tooth, and also in the roots of the tooth. So the crown is has the dentine, the enamel, and also some of the pulp, and then the roots have most of the nerve of the tooth, as you can see, and the tooth is within the bone. So around the tooth, around the roots of the tooth, we have bone, and the bone connects to the tooth via the periodontal ligament. So there are periodontal ligaments all the way down the roots and all the way around the roots of the tooth, and the periodontal ligaments join the tooth via a structure called the cementum, and they join the bone essentially. So if there's damage to the periodontal ligament of a tooth, the tooth will become mobile. There's different degrees of mobility, like grade 1, grade 2, and grade 3. So the periodontal ligament is like the suspension, suspension mechanism of the tooth. Because the tooth is never completely in one position, it's surrounded by this suspension structure around it called the periodontal ligament, which is a very complex and important part of the overall anatomy of the mouth and the tooth. Okay, but today's discussion is not to go into too much detail about that. It's just to show everybody just the general anatomy of a tooth. As we know, we have blood vessels inside the tooth, and the nerve of the tooth is inside the tooth. And so the blood vessels supply the nutrients to the nerve and the cells inside the tooth, inside the pulp of every tooth. So they're very important. So the next slide is about. So the discussion is about tooth hypersensitivity. So it can be present at any age, and it can have a significant effect on the individual's quality of life. Although up to 50% of people do not normally consult their dentist, unfortunately. So half of us just generally just accept the sensitivity, and they don't see their dentist for help. And some clinicians may also consider some dentists may consider this dental problem as a sort of like a nuisance problem, because it just comes and goes, and they maybe they're not sure how to manage it. And so what we need to do is find out whether a patient suffers. Finding out whether a patient suffers from dentine hypersensitivity depends on the clinician asking the right questions, the dentist asking the right questions, and listening closely to the patient's reply. Both patients and dental professionals may view tooth sensitivity as a relatively minor problem due to its sort of transient nature, but the challenge is nevertheless for the dentist to manage the condition successfully, of course, with cooperation of their patient, full cooperation of their patient. There are many obstacles or barriers to patients receiving dental care. As you may know, some patients are scared of the pain of dental treatments or going to the dentist, the cost of dental treatments. They may be too busy in their day-to-day life. They may have had a bad experience in the past. As a child, they may have had a bad experience at the dentist, and these are some of the reasons why people don't visit the dentist, and they may worry there is a serious problem, for example, and they don't really want to, confront the problem at that moment, or they may have a fear about the sounds and smells of the dental office. less common reasons. And of course now the current restrictions surrounding the COVID-19 pandemic. So there are many reasons, many different reasons why patients don't, barriers why people do not receive dental care, which ties in with the whole 50% of people don't really go and see their dentist for help regarding this problem, tooth sensitivity. Sometimes people self-treat complaints. They may try to self-treat this, and also self-treat toothache, which may or may not be a good idea, really. So the most common causes of tooth hypersensitivity are abrasion, abfraction. These are terms that I'm sure you've heard in previous lectures that I have given. Abrasion, abfraction, erosion. These are common causes of this problem. Gingival recession, gum recession, the quality of the buccal bone, periodontal gum disease, and the treatment of periodontal disease can cause this problem. Surgical and restorative procedures. For example, sometimes if a person has had, for example, a tooth removed, the teeth next to that tooth may be very sensitive for a period of time. Sometimes if a patient has had a filling or some other form of procedure like a crown or a filling, they may develop this transient sensitivity, and sometimes they need some help with that. And also patients' destructive habits. Clenching and grinding of your teeth can cause this problem, sensitivity. Overbrushing certainly can cause hypersensitivity, and also dietary and social habits, which we'll go into in more detail. So this is some photos of causes of tooth surface loss, also known as tooth wear. So we have the common presentation of attrition, where the teeth are wearing down due to grinding at night. Often that's stress related. And then there's the abfraction, which is another cause of tooth sensitivity. Erosion is another cause of tooth sensitivity, hypersensitivity, and it can be another cause of. Although you may have these dental problems and may not suffer from any tooth hypersensitivity, but there's a possibility you will if you have these conditions. If one has these conditions, and abrasion as well, which is related to overbrushing. So the fourth one, abrasion, is when we brush too hard, we scraping and brushing too hard, which is a very common problem. So gum recession can also cause dentine hypersensitivity. So this is where, for whatever reason, there's different reasons why this can happen. For example, overbrushing can cause this, brushing too hard, or maybe using sort of habits which we shouldn't, can cause the gums to become damaged. For example, some people may pick the gum, which is rare, but this can cause that. Mainly overbrushing. Sometimes orthodontic treatment can cause gum recession. As age is also related, gum recession can develop as we grow older. So gum recession can cause tooth sensitivity as well, which is something that needs to be taken seriously by the dentist and the patient. So the causes of dentine hypersensitivity. So tooth wear, of course, dentine hypersensitivity has also been considered as a tooth wear phenomenon. as you saw previously, and is characterized by erosion, which may open the dentinal tubules of the exposed dentine surface and initiate the tooth wear lesions. So sensitivity arises when the dentinal tubules in the dentine become exposed. Well, when the dentine becomes exposed, and then the tubules are open, and then the pain, this transient sharp pain arises. Scaling and debriding in the surgery can cause damage to the tooth surface over time, as can habits such as consumption of acidic drinks or brushing too soon after drinking. If the dentine has become exposed, the dentinal tubules will be patent, and consequently stimuli such as cold may initiate minute fluid movement within the tubules, initiating sensitivity. It should be noted, however, that not all exposed dentine is sensitive. So there are lots of people who have exposed dentine, and they don't have this problem. They don't complain about tooth sensitivity, but equally, there are some who do due to that. So dentine hypersensitivity, there's the theory of hydrodynamic theory. It promotes two basic approaches for treating dentine hypersensitivity. So to occlude the patent tubules and so reduce any stimulus-evoked fluid movements, and reduce intradental nerve excitability so that nerves do not respond to stimulus-evoked fluid movements. So if you see in this photo here, just go back, sorry. So when the dentine is exposed, for example, due to the gums receding, and then there's a fluid, then there's a stimulus, for example, cold water or ice cream or something, or chemical, which then results in the fluid here in the dentine, so the enamel, the fluid in the dentine tubules moves, and this excites the odontoblasts here, and that triggers this short, sharp pain. And the nerve receptors in the pulp are activated. So the diagnosis, there are three main categories of patients with tooth sensitivity, hypersensitivity. There are patients who have relatively healthy mouths, and just they brush too hard. So overzealous oral hygiene and brushing. Then there are patients who complain of this problem due to gum disease and or its treatment, and they may also have aesthetic concerns relating to the loss of gingival tissue. And then there are patients who have tooth wear problems, and they experience dentine hypersensitivity. So these are the three main categories of patients who present with this dental problem. And so it's important for the clinicians to be aware of how to diagnose how to diagnose tooth sensitivity, as well as how to monitor and treat it by using a combination of over-the-counter or in-office treatments, depending on the severity of the problem. It's also, many dentists find diagnosing this tooth hypersensitivity difficult, although dental hygienists often have a better understanding of the condition and its impact on the quality of life. If we give a patient cold water to rinse their mouth out, they may often give you an indication they have sensitivity. So a full diagnosis of tooth hypersensitivity should include a thorough history of the complaint, and an assessment of the severity and the extent of the problem, and a clinical examination to rule out any other conditions with a similar presentation. For example, a cracked tooth, that can also give a short, sharp, transient-like type of pain, fractured fillings or teeth or dental caries. As there are several conditions with similar symptoms to tooth hypersensitivity, a simple way to check the diagnosis is to blow cold air from a syringe on the affected tooth. If there is an initial pain, but this gradually diminishes in severity, it is likely to be tooth hypersensitivity. If on the other hand the pain persists, we need to reconsider the diagnosis. we ask our patient to rate the level of the pain. For example, on a scale of 1 to 10, we can apply desensitizing paste or varnish and retest. If the patient does not experience pain now, then a diagnosis of tooth hypersensitivity is likely. So it's essential to have a feedback loop to revisit the diagnosis and to be prepared to change the management strategy if the initial diagnosis appears to have been wrong or the treatment is not working. So we have to keep an open mind as to the diagnosis and whether or not it's helped our patients. If it has, that's fantastic. If it hasn't, we need to revisit and look for another cause of this pain. So as you can see here, there's a diagnostic test that we can do. So if the tooth is sensitive, we blow some cold air onto the part of the tooth where it's sensitive, where the dentine has been exposed. So the enamel is not there, the dentine has been exposed. And then we record the pain score. Then we apply some varnish and we wait a few minutes, and then we repeat the cold test. And then we record the pain score again. If the pain score has fallen, it's likely to be tooth hypersensitivity. If the score is unchanged, then it's unlikely to be tooth sensitivity, hypersensitivity. So education and management is very important. Education of the patient is central to the success of the management strategy. The patients need to change their behavior. Our patients need to change their behavior and take ownership of their mouth and alter their diet. For example, if it's acidic, to high in acidic foods and drinks, they need to modify their brushing technique. They need to reduce the consumption of high sugar energy drinks, for example, as required. Simply giving a patient just some desensitizing toothpaste, which I'm sure you've all seen, so it may not be the solution. It may not. It may be insufficient really with dealing with the underlying problem in the first place. So there can be a tendency to treat patients in a general way, but each patient is an individual with their own individual needs and concerns, and they need to understand the cause of their tooth hypersensitivity and be involved in its solution. In short, there is no single method of treating this problem, and therefore we need a number of different measures and solutions and products for the various presenting features. Okay. So if the sensitivity is quite mild, it's mild and generalized discomfort, it can be treated for a stepwise approach involving reducing or removing completely the cause, the predisposing factors, and having preventative measures to reduce the impact of acidic foods and drink, and recommending a desensitizing toothpaste. So that this is in a mild and generalized case of this problem. So reduce the cause and preventative measures, and recommending a desensitizing toothpaste. If, however, this does not improve the problem, the guidelines from the expert panel on dentine hypersensitivity have suggested a management scheme based on the 3 main categories of dentine hypersensitivity listed above. So simplified into the clinical evaluation, the patient education, and the preventative advice and corrective clinical outcomes specific to each grouping. So a simple treatment path is shown in figure 3. So the next slide shows the treatment levels of treatment for this dental problem. So level 0 is when you're just checking to see if the problem exists. So screening for dentine hypersensitivity. If it's diagnosed as being present, then level 1 is for a mild case with generalized discomfort. So we need to eliminate predisposing and etiological factors, and we need to use desensitizing toothpaste or mouthwash. So that's what we would recommend you to use. Modification of the toothbrushing technique, of course, if that's causing the problem. Dietary advice if that's causing the problem. So certainly that would be level 1. Level 2, if the pain still persists, so we've tried that and it's still persisting, the pain, then we need to apply some topical agents such as a varnish, and we need to use, again, desensitizing toothpaste or mouthwash, and again, prevention, including dietary advice. If the pain still persists, then level 3. Level 3 would involve more intervention by the dentist, so restorative treatments, for example, with filling, may be required, such as the GIC filling, or periodontal surgery to correct the gum recession, which is associated with that. So if there's a periodontal problem, gum surgery would be required. If it's more sort of covering the area, the exposed dentine, and the patent exposed dentine with some filling materials, if that helps, certainly. If that's the problem, then that's what your dentist would do. So there's three levels of intervention there for this problem. So there are lots of products available on the market claiming to improve the problem of tooth hypersensitivity, but many do not live up to their claims. There is an effective treatment, an effective toothpaste called Biomin F. It's a bioactive glass material, and it's called Biomin F. It has been shown to be effective against. It has been an effective treatment for this, for tooth hypersensitivity. Trials have been done at the Queen Mary University of London, and have demonstrated that delivering Biomin F precise combination of calcium, fluoride, and phosphate ions in a slow release format as the glass dissolves, forming fluoroapatite, which is deposited on the tooth surface and on the dentine surface, of course, and that enters and occludes the dentinal tubules, which are open patent. So Biomin F, this is what it looks like. If you want to, if you have this dental problem, of course, I would advise you to see your dentist first, and tell them the history of the problem and signs and symptoms you've had, and they will make a diagnosis, but they may recommend you to use a product such as Biomin F. So Biomin F contains a combination of calcium, fluoride, and phosphate ions, and it's incorporated into the structure of the bioactive glass. And after we brush with Biomin F, the particles adhere to the tooth surface, and they gradually dissolve over up to 12 hours, releasing these ions, these calcium, fluoride, and phosphate ions, and these and they promote effective remineralization of the tooth enamel through the production of fluoroapatite, the fluoride analog of natural tooth mineral. Fluoroapatite is preferentially deposited onto the walls as well of the exposed dentinal tubules, which occlude the tubules. Basically, they close the tubules and in the dentine, and that prevents the fluid flow that initiates this pain. Biomin F contains fluoride and a higher phosphates content, which aids the effectiveness and speed of fluoroapatite production. And fluoroapatite is more stable and resistant to acid attack than hydroxyapatite, formed by previous bioglass toothpaste. So some toothpaste, bioglass toothpaste, they form hydroxyapatite, which is not as stable as and resistant to acid attack as fluoroapatite. The Biomin F also starts working more quickly in the presence of acid in the mouth. for example, following consumption of an acidic drink. For people who don't want to use fluoride-containing toothpaste, there is the Biomin C, is available, and there is a fruit-flavored children's variant as well for kids, and it provides the same level of protection for young teeth. So that's the product there, and so fluoroapatite rapidly covers the dentine surface, and it occludes the tubules, and continues to do so over several hours, and it is more stable in the presence of acids than hydroxyapatite, which is a component of several manufactured toothpaste. So you may find like Sensodyne F or Colgate Pro-Sensitive, they may be less effective than Biomin F. Comparative studies have shown that Biomin is more effective than other toothpaste tested at the Queen Mary University of London due to its ability to deposit fluoroapatite, which is more acid resistant, and it provides improved tubule occlusion, stabilized pH, and effectively remineralize the enamel surface. So it helps with the enamel protection and dentine protection of your tooth, and it's more stable pH. So in conclusion, studies have shown that dentists are not confident maybe in diagnosing and managing dentine hypersensitivity. We have to offer practical advice to our patients via webinars and articles on this troublesome clinical condition, together with access to an effective treatment. It should provide clinicians and patients the confidence to successfully manage tooth hypersensitivity to the satisfaction of both the patient and the dentist. So we need to provide more practical advice. And yeah, that's great. So thank you for listening. Over to you.